case today about hemostasis in pediatric liver cell failure. We have a girl 11 years old presented to the emergency unit by vomiting, impaired conscious level. Her parents reported that 2 weeks earlier she had abdominal discomfort, yellow eyes, dark urine, and low-grade fever. She was advised to start a herbal medication categorized as liver support treatment and to stop protein diet and to increase in sugary diet, but she wasn't improved. Past medical and family history, no prior history of liver disease or coagulopathy, no significant past medical history, no family history of liver diseases. About vaccination history, she received only the compulsory vaccines. Physical examination, general appearance, she was ill-looking, lethargic, skin, jaundice, and mild dehydration. Vital signs, temperature 37.8, heart rate 120, respiratory rate 22, blood pressure 90/60, and random blood sugar was 100. Abdominal examination revealed just mild hepatomegaly, and neurological examination, she was drowsy but arousable, and no focal neurological deficits. Laboratory investigations revealed CBC hemoglobin 11, platelets 355,000, TLC 10,000, ALT was 1,459, AST 1,341, alkaline phosphatase 856, total bilirubin was 6.7 and direct bilirubin 3.5. INR was 3 despite receiving vitamin K, and hepatitis A IgM was positive. To summarize, في jaundice, lethargy, shooting ALT and AST, we increased bilirubin, impaired INR even after vitamin K administration, and have IgM positive. So it's a case of fulminant liver cell failure due to hepatitis A infection. Regarding the management plan, the immediate management, she should be nursing in a quiet environment, and it's better to be admitted at ICU. Venous access for resuscitation, withdrawal of labs needed for multi-system assessment as CBC, albumin, ammonia, glucose, blood gases, electrolytes, and kidney functions. Close monitoring of vital signs, random blood sugar, oxygen saturation, and neurological assessment. The supportive treatment, oxygen support, replace intravascular volume with normal saline if hypotensive, and try to maintain normoglycemia with IV fluids, and it's better to be 85% of the maintenance. Proton pump inhibitors, prophylactic broad-spectrum antibiotics, and antifungal. N-acetylcysteine may be used in non-acetaminophen liver cell failure also to decrease liver injury and improve management of complications. أول حاجة hepatic encephalopathy or increased intracranial tension. She should admitted at ICU for close monitoring and neurological evaluation frequently. Head elevation at 30 to 35 degrees. And if she developed grade 3 or 4 encephalopathy, should be electively intubated. Maintaining normoglycemia and normal blood pressure, to use inotropes if needed. Maintain serum sodium between 145 to 155 to improve cerebral blood flow. Avoid any risk factor that increase hepatic encephalopathy like hypoxia, constipation, electrolyte disturbance, GIT bleeding, or infection. تاني حاجة, measures to decrease production and absorption of ammonia. There is no rule for protein exclusion in children. We can reduce the intake only. Oral lactulose and lactulose enema, oral antibiotics as neomycin. If ammonia more than 150 may be an indication for continuous renal replacement therapy. And we should correct any electrolyte or acid-base imbalance. Regarding the management of acute hepatitis A virus, we should stop all medications. Good hygiene and frequent hand hygiene, adequate hydration and clean food, isolation from school for 7 days after onset of jaundice, and follow-up liver functions till be normalized. We shouldn't use unneeded medications or start. هي في liver cell failure بس فابتدينا prophylactic antibiotics, لكن in general اللي have infection we shouldn't start antibiotic أو use the unneeded medications, like we shouldn't increase sugary food or exclude protein from diet. And we shouldn't miss following up liver function test and normalization, as it may be a triggering factor to chronic illness like Wilson disease or autoimmune hepatitis. And we shouldn't forget to receive hepatitis A vaccine with the compulsory vaccination schedule. لا.
يعني المحزن لغايه النهارده ان الهيباتيتس اي فاكسين از نوت كومبالسري ان ايجيبت، بس لما يكون عندنا يا جماعه من فضلكم اندكس كيس اوف هيباتيتس اي لازم ننصح كل المخالطين ان ياخدوا هيباتيتس اي فاكسين if you diagnose the case within 14 days of the onset of jaundice. يعني لو جالك النهارده طفل عنده هيباتيتس اي في خلال 14 يوم الاولانيه، قول لاهاليه يطعموا الاطفال اللي معاه في البيت، سواء اخواته او قرايبه اللي عايشين معاهم في البيت. الكبار في الغالب بيبقوا اميون زي حالاتنا كده، يطعموه within 14 days، لان حتى جماعه بتوع الوصل واللقاح مش عارفين الحكايه دي. ببعت السبز يطعمه، يجي يقول لك اصله اتعرض لحاله هيباتيتس اي. يس، اتعرض لحاله هيباتيتس اي and he is now infected but he is not diseased. If you give him the vaccine you will make him protected in spite of the infection. يعني يبقى في زي كده سباق بين الفيروس اللي انفكتد هيم والانتي بودي اللي هيطلعوا الفاكسين. لو لحقته في 14 يوم مش هيجي له الديزيز، لو ما لحقتوش في 14 يوم ممكن يجي له الديزيز بس milder if he is vaccinated. So contacts of hepatitis A must be given hepatitis A vaccine. في امريكا دلوقتي بعد سنه بيطعموا hepatitis A compulsory، يعني امريكا اللي ما فيهاش hepatitis A اصلا it's a compulsory vaccine. اول جرعه يا دكتوره وفاء معروفه انها مثلا عند سنه، وبعد كده سنه ونص، ده الروتين. لا، سنه وسنه ونص في السعوديه وكده. يس بس في امريكا يس سنه وبعد كده سنه ونص. في الانفكشنز بقى، الحالات اللي اتعرضت لهيباتيتس اي ممكن تديها فيري رابيد دوز بدري بعد 3 شهور. يس، ما في كومبارس في السعوديه من سنين.
بس عايزه اقول لحضرتك انه ممكن في مسافه، ودي بنقابلها كنا كتير قوي، انه ما بين الجرعه الاولى والثانيه في الهيباتيتس اي احنا دايما مع الكومبالسري فاكسينيشنز اللي عند 18 شهر كنا بندي الجرعه الاولى من هيباتيتس اي والتكمله بتاعتها في عمر السنتين. لو حصل وان الام كسلت او قالت دي تطعيمه مش مهمه وانا خلصت معاها لغايه 12 شهر انها ممكن تدي الجرعه الثانيه، بعد كده تبدا الجرعه السكيدول
هيباتيتس اي فاكسين might be given بعد 6 شهور باي مده، مش مشكله.
What about the hemostatic challenge in this case and how can we manage the prolonged INR in this case؟ هنكمل مع دكتور محمد.
دكتور محمد الكومي مدرس الهيماتولوجي في القصر العيني هيكلمنا على how to manage this very prolonged INR despite administration of vitamin K. تفضل دكتور محمد.
Thank you, Dr. Alaa, and I'd like to express my thanks and gratitude for the honor of participation in this conference. Regarding the hemostatic complication in this case, as Dr. Alaa said, pediatric acute liver failure is a life-threatening illness with multiple metabolic derangement. One of them is the sudden onset of coagulopathy. This is due to the fact that the liver is the site of the majority of synthesis of the majority of blood coagulation factors. So that led people historically to the belief that the PULF patient is auto-anticoagulated. PULF stands for pediatric acute liver failure. However, this belief has been challenged as the clinically significant bleeding rates has been found to be low. And this was found later that actually what happens is a state of rebalanced hemostasis in which there is a parallel reduction of anticoagulant factors along with procoagulant factors. Before we can discuss the changes that occurs in PULF patient, first a quick review of the normal physiology of the phases of hemostasis. There are 4 phases of hemostasis. The vasoconstriction phase occurs at the site of the blood vessel injury to limit oozing of blood. Then comes the primary hemostasis phase in which platelet aggregates at the site of the blood vessel injury to cause a platelet block. Then the secondary hemostasis phase in which there is a cascade-like activation of blood coagulation factors that ends in the production of a strong fibrin mesh that plug the site of the vessel injury. And then the last phase, the fibrinolytic phase, in which it limits the production of the fibrin mesh to the site of the injury and prevent overproduction of fibrinogen. In all these phases, the primary hemostasis, the secondary hemostasis, and fibrinolysis, there is changes in the PULF patient that leads to both bleeding and thrombosis. We will discuss each of these phases individually. And regarding the primary hemostasis, the changes that occurs in pediatric acute liver failure, the changes that leads to bleeding include decrease in the platelet count due to decrease in the production of thrombopoietin by the liver, there is a decrease in the platelet function due to the metabolic derangement, and there is an increase of nitric oxide and prostacyclin, which further impair the platelet function. On the other side, there is an increase in the von Willebrand factor due to increased synthesis and secretion, and decrease in its natural inhibitor, the ADAMTS13. This leads to more and more increase in the von Willebrand factor, and of course it's known to promote platelet aggregation. So there is some sort of balance between bleeding and thrombosis in the primary hemostasis. Regarding the secondary hemostasis, first a quick review of the physiology to better understand. We have two pathways of activation of the secondary hemostasis. The intrinsic pathway begins with factor 12, activating factor 11. Factor 11 activates factor 9. With the help of von Willebrand and the factor 8, it activates the factor 10, and this is the start of the common pathway. There is the extrinsic pathway that begins with activation of factor 7 that directly activates factor 10. The common pathway continues with activation of prothrombin by the help of factor 5 and converting into thrombin. Thrombin then activates the fibrinogen to fibrin, and it also activates factor 13 that stabilizes the fibrin into a cross-linked fibrin. There is a natural anti-inhibitor or natural inhibitors to this pathway. One of them is antithrombin 3 that inhibits multiple coagulation factors like 11, 9, 10, and thrombin. And there is the protein C and its cofactor protein S that inhibits factor 8 and factor 5. What happens to this physiology in the PULF patient? There is a decrease in all of the coagulation factors, and there is also an impairment in the function of fibrinogen, causing dysfibrinogenemia. This leads to bleeding, of course. But on the other hand, there is an increase in the von Willebrand as discussed, and the increase in factor 8 level. It's the only factors that increases in the PULF patient. And there is a decrease in the antithrombin 3 and the protein C and S, which are the natural inhibitor of this pathway. This leads to thrombosis. So again, there are both changes that balance each other, bleeding and thrombosis. What about the fibrinolytic phase? Again, a quick review of the physiology to understand what happens. The cross-linked fibrin is converted to fibrin degradation product by plasmine. Plasmine is activated from its precursor, the plasminogen, by tissue plasminogen activator. There is a natural inhibitor to this activator called the plasminogen activator inhibitor, and there are two other inhibitors to this pathway. One of them, the thrombin activatable fibrinolysis inhibitor, or TAFI, prevents or inhibits plasminogen conversion to plasmine, and the plasmin inhibitor. What happens in the PULF patient? There is a decrease in the inhibitors and the increase in the activator. This leads to more fibrinolysis and hence more bleeding. But on the other hand, there is a decrease in the plasminogen and the increase in the inhibitor of the activator, and this leads to the opposite side thrombosis. So again, in this phase also there is a balance between bleeding and thrombosis. So with that said, then how to measure the actual bleeding risk? Apparently, the conventional laboratory test like PT, PTT, INR does not describe the whole picture, as it only measures the procoagulant factors. There are newer tests called the viscoelastic hemostatic assays, like thromboelastography. It actually measures the physical clot properties after the different interplay between thrombosis and bleeding. It describes how the blood clot function with all these factors in interplay. The principle of the test is simple. A drop of blood is put on a rotating cup with a pin immersed on it. Under conditions that simulate the in vivo environment. This leads to the formation of clot. The clot forms a torque or a twisting pressure on the pin, and this is converted to an electrical signal and graphed into a chart. If there is balance between the thrombosis and the bleeding, the result of the test will be normal. If there is a tipping of the balance into bleeding or thrombosis, it will differ accordingly or will be abnormal accordingly. This is the normal thromboelastogram. It can measure different aspects of the blood clot. It can measure the secondary hemostasis phase. This is the reaction time. It is the time till initiation of fibrin clot, and it is very sensitive to changes to secondary hemostasis and blood coagulation factor. This is the K value. It's time to achieve 20 millimeter amplitude. It's very sensitive to changes in fibrinogen, and this is the maximum amplitude. It is the maximum strength of the clot, very sensitive to changes to platelets. And the LY30, it is the time or the rate of fibrinolysis 30 minutes after the maximum amplitude. Very sensitive to changes to fibrinolysis. So it can measure different aspects or give a holistic picture of the blood coagulation, the secondary hemostasis, the fibrinogen, the platelets, and the fibrinolysis. Just a quick examples. The top of the figure, there is the normal hemostatic result if the patient has a normal balance between bleeding and the thrombosis. However, when there is a balance that tipping into the hemorrhagic side, this occurs with secondary hemostatic affection or decrease in coagulation factor. And this picture occurs with low platelet count or function, a maximum amplitude decrease. The K value decreases in low fibrinogen, and when fibrinolyzes, there is an increase in LY30. On the other hand, if it tips to the thrombotic side, there will be increase in the maximal amplitude in the platelet hypercoagulability, or if there is enzymatic hypercoagulability in the secondary hemostatic phase, it will decrease the reaction time. So it's give a holistic picture. However, this test unfortunately is not present in Egypt. The challenges at the management of PULF patient, there is no transfusion guidelines available for pediatric acute liver failure. The currently conventional laboratory test, like we discussed, does not measure the bleeding risk accurately, and the physical hemostatic assays promising, however, the studies in PULF are still lacking. So how to measure? Generally, we give vitamin K and prevent the factors that decreases it. We prevent and prompt treating the bacterial infections and renal impairment at DIC. These conditions may imbalance more the hemostasis. We give H2 blocker or proton pump inhibitors if there is gastric bleeding, especially in ICU. And most importantly, do not give plasma or any blood product just based on INR. Only give if there is an active bleeding or if an invasive procedure is planned. Adopt a restrictive transfusion strategy. Keep the hemoglobin above 7, but keep the target between 7 and 9, as higher transfusion targets has been associated with more morbidity due to volume overload and dilution. If you are planning to do an invasive procedure, keep the INR below 1.5, keep the PT prothrombin time 3 seconds from control, keep platelets above 80,000 if you're doing liver biopsy, above 50,000 for GIT endoscopic intervention, and keep it above 100,000 if you're doing a major neurological procedure. If there is an actual active bleeding and it is caused by thrombocytopenia or thromboasthenia, platelet function defect, keep the platelets above 50,000. How about the correction of coagulopathy? If there is an active bleeding, the correction of secondary hemostasis, or if there is an invasive procedure planned. The obvious and most widely used option of the fresh frozen plasma that has the advantage of containing coagulant and the anticoagulant. However, it has the major disadvantage of having large volume with all of its complications, and of course the complication of transfusion. Other options include cryoprecipitate. It is a blood product preparation that is rich in fibrinogen and other factors, but it is given to correct the fibrinogen level or if bleeding is caused by low fibrinogen level. Here, the important role of the physical hemostatic assays is illustrated as it can diagnose this condition with ease and rapidly. The prothrombin complex concentrate corrects the vitamin K dependent decrease in vitamin K dependent factors. It can be given if vitamin K alone does not correct. However, it doesn't correct the coagulopathy. It has the advantage of a small volume. However, disadvantage of the risk of thrombosis and cost and lack of studies in PULF again. Factor 7 concentrate can be used also. But it has the disadvantage again of risk of thrombosis and cost and lack of studies. It has, of course, the advantage of being a very small volume or minimal volume. It can be used in treating bleeding in a volume overloaded patient. The tranexamic acid can be used if the patient has bleeding due to increased fibrinolysis. So what should I do in this particular case, in our particular case? You can give vitamin K, give gastric protection, prevention and prompt treatment for bacterial infection, renal impairment at DIC. Keep the hemoglobin above 7, keep the target between 7 and 9 grams per deciliter. Do not give plasma or any blood product, again, based only on impaired coagulation profile. Only give it if there is an active bleeding or invasive procedure is planned. Consider doing a factor 5 level as a guide for liver transplantation, as low level has been associated with a strong indication for liver transplantation. Thank you.
بنشكر الدكتور محمد الكومي.
دكتور محمد. Very clear message. Very clear message. Don't treat papers.
Always look for your patient. Thank you so much. Very well prepared.
آلاء كانت بتتكلم على انه في ستاديز كتير في الليترتشر بتقول انه الاولاد دولت اللي عندهم acute liver cell failure ومحتاج انه يخش ICU تلتهم لتلتينهم هيموتوا من بكتيريال سبسس. ولو انت استنيت انك تبتدي الانتي بكتيريال لما تبان السبسس بتكون تو ليت. فعشان كده في جايد لاينز، معلش في جايد لاينز بتقول مادام هيخش ICU يعني زي البنت بتاعتنا you can consider انك تدي antibiotics. معلش كمل الدسكشن. انا بس عايزه اقول ان الاء جايباها من جايد لاينز. يمكن في الناس العاديه اللي عندهم هيباتيتس A الهيباتيتس A ما بنديش antibiotics، والعلاج بتاع الهيباتيتس A is not symptomatic, it is conservative. علشان هيباتيتس A اللي عايز يدي دواء في هيباتيتس A لازم تكون in a hospital setting، لكن ما بنديش علاج في الهيباتيتس A. احنا بنشكر حضراتكم جدا جدا جدا، والدكتوره سوسن هتقفل.